Hi, my name is John Scott, and I'm presenting for our group on our case study of a 20-year-old alert and oriented Caucasian female presented to the emergency room with a worsening abdominal pain. Her last menstrual period was 1 week ago, and she reports no known drug allergies. She reports gradual onset last night of generalized crampy and dull abdominal pain and is now 16 hours post onset of symptoms. Patient reports right lower quadrant as the source of the pain now, that is sharp in quality. Pain is described as constant, 6 out of 10 non-radiating. And patient had nausea and vomiting this morning with no hematemesis or other abnormalities in the vomit. Patient is feeling flushed but denies fever and chills and has regular bowel movements and negative urinary symptoms. She is sexually active and uses condoms regularly for birth control and denies any past surgeries or illicit drug use. Physical exam findings were negative for any abnormalities on inspection, no distension, no bruising or scars or anything abnormal on inspection. Bowel sounds were present in all 4 quadrants. She had notable right lower quadrant abdominal guarding on light palpation and then more so on deep palpation, specifically to the right lower quadrant there. She also had positive rebound tenderness. Her liver and splenic margins were within normal limits and unremarkable. Abdominal percussion findings were also unremarkable, and the patient exhibits increased pain with deep inspiration. She also has a positive psoas sign and obturator sign and Rovsig sign. Rectal exam revealed right side tenderness, and pelvic exam and inguinal exam were unremarkable. Patient also had negative costovertebral angle tenderness. So based upon our physical exam and history, our acute appendicitis is our number one differential diagnosis. Based upon the patient's presentation of right lower quadrant with positive obturator, psoas, and Rovsig signs, as well as the positive rebound tenderness with nausea and vomiting, patient just generally appears ill. This is our leading diagnosis. The second in line would be ovarian torsion with very similar signs and symptoms to that of the acute appendicitis, and the patient is of childbearing years and still has has never had a radical hysterectomy for any reason. Peritonitis would be our number 3 differential diagnosis, also with the signs of rebound tenderness and guarding to the right lower quadrant. And finally, our 4th in line would be pelvic inflammatory disease. At this point, this patient is sexually active and is possible for many STDs that could lead to pelvic inflammatory disease.